appreciated. Are you able to see my screen clearly?
Yes, we can. Yeah, we can hear
Thank
you.
you. Thank you very much. So I really do appreciate you guys giving me this opportunity to present and promote some of the work that I've been involved in this collaboration between the International Academy of Cytopathology and the International Agency in Research of Cancer under the WHO in trying to develop an international system for reporting soft tissue cytopathology. You know, we've been talking a little bit about going back to Vancouver and how long it's been and since I've been to Vancouver. In fact, now that you mention all those dates, I sort of recall when I was a medical student nearly 20 years ago, 19 years ago, I did do an elective in Vancouver where I had spent a few weeks with Dr. Nemo and Dr. Churg. I believe at that time, a medical student by the name of Guanming Hong was also there with me. She's also now in British Columbia and a good friend of mine. So it's funny how time has just run by me here, but hopefully you'll enjoy this presentation. I have no potential conflicts of interest in relationship to this presentation. So what I would like to do today is try to introduce everyone to an upcoming report that we're going to have published for an attempt at creating a reporting system for soft tissue cytopathology. And the reason why we feel that this can be done is because I think now that we have such a huge fund of molecular and immunohistochemical ancillary testing for soft tissue pathology, we can really sort of utilize that material to render a specific interpretation based on cytomorphology and use of ancillary testing. And we really need to now understand the role and, of course, the limitations of cytopathology in soft tissue tumors. So let's start with a case example. We saw in our fine needle aspiration clinic here in Boston, a 21-year-old male. He initially presented to his ENT surgeon, reporting a 3-week history of a left temple mass. You can see here within the temporalis muscle. And we have a close relationship with our ENT surgeons who oftentimes send them same day for a fine needle aspiration biopsy. So he was seen by another cytopathologist who performed a fine needle aspiration biopsy in the FNA clinic. The smears themselves show a relatively cellular smear composed of both cohesive groups and abundant single cells in the background. And at higher power, you can recognize that these cells have a very monomorphic morphology. All the cells look essentially the same, plump spindle cells with single cells in the background showing either naked nuclei or long cytoplasmic processes. So if we step back and ask ourselves, well, how could we categorize this based on the cytomorphology so far? I think we would get some variable answers. Some of us might suggest that there is just a generic atypical spindle cell lesion, for instance. Some of us might categorize this as a neoplasm, so suggest that this is a spindle cell neoplasm of some sort. Some emboldened might actually suggest that given the cytomorphology that this is malignant and suggest that this is in fact a spindle cell sarcoma not otherwise specified without the ability to do ancillary testing. So with that, I think I would like to try to introduce this reporting system for soft tissue cytopathology. But before we go there, we need to ask ourselves, you know, cytopathology is already full of a number of reporting systems, whether you like them or don't like them. Do we really need another reporting system in cytopathology? And in fact, even if we did, do we need one for soft tissue cytopathology, an even smaller subset of that? And in fact, do we even have the literature that supports the requirements for a reporting system in soft tissue cytopathology? And borrowing somewhat from the molecular pathology and immunohistochemical profiling of a lot of these tumors on small biopsies, I think we can certainly say that we do have what requirements are made for a reporting system in soft tissue cytopathology. So where are we in terms of the research field of soft tissue pathology and cytopathology? We are falling a little bit behind our pulmonary colleagues, our melanoma colleagues in terms of identifying targetable therapies from a clinical perspective. But one exciting thing that's been happening in a number of institutions is recognizing the role that these fusion products have in the development of oncogenesis, such as the synovial sarcoma fusion product developing, or rather its role in histone modification, or from our institution here, the role it has in chromatin remodeling complexes. So very, very interesting stuff, really helps us understand the pathobiology of these malignancies in hopes of getting to that point where we can develop some targeted therapies. But for the most part, a lot of the publications coming out from a clinical perspective tends to be similar to these, where we're subdividing rarer and rarer neoplasms into more difficult to classify categories, such as this in ALK rearranged mesenchymal neoplasms that do not, superficially at least, resemble inflammatory myofibroblastic tumors. Alternatively, we are identifying rare tumors such as this pseudoendocrine sarcomas from one particular author who's got a huge fund of experience, Christopher Fletcher, for instance, where these are going to be exceptionally rare in most other institutions. There's been so many of these, in fact, that Dr. Fulp out of the Mayo Clinic has published this somewhat hilariously titled review article trying to summarize a lot of this data. It's an excellent article to help understand a lot of this material and a lot of these novel things that have been identified. And I do suggest that we do take a look at it if you do have time. How are we doing from the cytopathology perspective? Well, we typically follow suit. A new entity or immunohistochemical marker is identified on surgical pathology literature, and we identify usually a smaller subset, myself to be blamed as well, where we then publish the cytomorphologic features or correlate on cell blocks, suggesting that yes, these markers that we identify on tissue can also be identified on cell block preparation as well. That being said, the vast majority of tumors that we will see from both a soft tissue perspective and a cytopathology perspective have been well established. Their criteria for diagnosis are pretty well understood, and they're common enough that we will see them on a general practice perspective as well. And this has been largely summarized in the most recent edition, the 5th edition of the WHO Blue Book on Soft Tissue and Bone Tumors. If you look at any particular chapter in the WHO for soft tissue tumors, such as this one on synovial sarcoma, one very nice thing that they've done is actually mention and establish the essential and desirable features for making a diagnosis. For instance, here, the essential features of synovial sarcoma, a monomorphic blue spindle cell sarcoma, absolutely showing variable epithelial differentiation with diffuse and strong nuclear staining for TLE1, absolutely, and desirable to find the fusion product. Now you ask yourselves, well, what are the cytologic features of synovial sarcoma? And they try to address that in a section on cytology. For FNA material, preparation of a cell block is advocated because a conclusive diagnosis of synovial sarcoma heavily relies on diagnostic molecular studies, which is absolutely true, but is also true of surgical pathology and core biopsies. So this does not really address the cytologic features that one might want to recognize for synovial sarcoma if faced with an aspirate of a potential spindle cell sarcoma. As another example, the gastrointestinal stromal tumors, the cytology section claims that it's not even clinically relevant, which I would argue is a little bit surprising, seeing a significant number, at least in our institution, of gastrointestinal stromal tumors are diagnosed based on endoscopic ultrasound guided fine needle aspiration biopsies. So it certainly is clinically relevant. And this is essentially where our group sought to try to fill in the gaps in regards to the Blue Book. Now, cytopathology is no stranger to reporting systems. We've had several of them over the decades. Now we're in the 3rd edition of the Bethesda system for reporting cervical cytology, led by my colleague and former director of cytopathology here, Dr. David Wilbur. And obviously the success of these systems has been through allowing a unified language for reporting and tying in malignancy and treatment algorithms. Still to this day, despite the emergence of HPV's importance, we still utilize the prior cytopathology interpretation categories in that risk classification system. Obviously, building off of that, a number of other reporting systems have been created. This one by Edmund Sebus, my neighbor here at the Brigham and Women's Hospital, on the Bethesda system for reporting thyroid cytology. They then started to identify that they want to go to more unique and beautiful places such as Milan. So this one by my colleague here at MGH, Bill Faquin, on the reporting of salivary gland cytology, the Paris system now of reporting urinary cytology. The former director here, Dr. Martha Pittman, reported on the pancreaticobiliary cytology system for reporting, and it continues with respiratory and fluid cytopathology. So, do we really need another cytopathology reporting system? Well, if we can establish that there are criteria for a cytopathologic diagnosis that correlates with biological behavior and management recommendations, then I think we can create one. But most importantly, do we need one for soft tissue cytopathology, as I mentioned earlier? And this is where I think we're really filling in our role, which is to identify that there are gaps in the WHO description of the cytopathology of these soft tissue tumors, and that we can supplement that with our descriptions. We've obviously got cytologic diagnostic criteria. We've known several of them for years now of a certain subset, of course, of soft tissue tumors. And we're going to try to limit, based on our algorithms, the number of just generic spindle cell tumors that would require otherwise a repeat biopsy or delays in treatment. Now, when we ask ourselves, does the literature support a new reporting system for soft tissue cytopathology? Well, I think it certainly does. We have sufficient fund of knowledge now. We have to recognize that there are certain entities where we can make a diagnosis of a soft tissue tumor based on cytomorphology alone. Schwannomas, for instance, are pretty classical in their appearance. There is a growing number of cases where we can make a diagnosis on cytopathology, as well as the addition of ancillary testing, such as the growing number of molecular studies that have become available, as well as ancillary testing through immunohistochemistry, where we have surrogates for those molecular events available to us. But there is a limit. There's always going to be this limit in cytopathology, and plus or minus ancillary testing, where the lack of architecture or the lack of sampling a large area of the tumor will limit our ability to make a diagnosis. And we need to recognize that. We will not be able to be perfect on all cases. I think the biggest challenge we have in cytopathology, however, is our ability to stratify the risk of malignancy and create a proposed interpretive categories where there will have an understanding algorithm of what the next step in management would be. And that's something we're trying to work through now. Obviously, from the molecular perspective in particular, some colleagues of mine here at MG8, Dr. John Iafredi and Long Li, developed almost a decade ago now this anchored multiplex PCR for targeted next generation sequencing, which allows us to pool and multiplex a huge number of possible gene fusions and identify those on small samples. And this has really been helped us open up our ability to do molecular testing on a large number of our cases. Obviously, the way we do it in our institution is not the same, and there's multiple ways that it can be done, such as those using the nanostring fluorescence probe, targeting fusion specifically, the utilization of ultra high molecular weight genomic DNA through this company BioNano has emerged as well. This interesting project that was performed by some colleagues of mine here at MGH, utilizing a small USB dongle that attaches to your laptop, essentially, where you can place specimen in and it starts to spit out sequencing data directly onto your laptop for potentially clinical testing of fusion detection. So it has become widely available, and we and others have actually looked at how it has impacted our service in terms of clinical practice in soft tissue and bones pathology. What we've identified is there's certainly a subset where it confirms our diagnosis. We submit it for fusion assay. We think it's a Ewing sarcoma. Sure enough, we identified the EWSR1 rearrangement with the appropriate fusion partner. That's the nice thing about these fusion assays. We can identify those fusion partners. We certainly see a second subset, where a difficult cytomorphologic differential is built. There's a lot of overlap between some of these entities, and perhaps we can't make a definitive diagnosis due to the small size of a biopsy. Submit to this fusion assay. Sure enough, it pops out a specific fusion that answers our differential diagnosis and helps us solidify a definitive diagnosis. However, as I've already alluded to, there is a growing number of subset of cases where difficult cytomorphologic features, immunohistochemical panel has not allowed us to render a specific interpretation. We send it for fusion assay and comes back as fusion that has never been described or is of uncertain significance. And what exactly do we do with this growing fund of cases? We're still trying to learn and work our way through that. In fact, Dr. Dixon out in Toronto has essentially evaluated soft tissue tumors through an RNA-seq agnostic platform where he's essentially discovering novel fusions in a lot of these rare tumors, which is both exciting and complicating at the same time, given how difficult it already is to try to render diagnoses in soft tissue tumors. Ultimately, however, this publication from the French group summarizes what I think we all agree with, which is that molecular genetic testing is essentially mandatory for accurate classification for a lot of our soft tissue sarcomas. And essentially, even amongst experts in the field, we're going to disagree without the advent or availability of molecular testing to help classify these tumors. That being said, obviously, we don't all have access to these sophisticated molecular tests, but what we do oftentimes have access to is immunohistochemistry. And this nice publication from a former colleague of mine, Dr. Mark Dupre, who's now in University of Manitoba, essentially summarizes how to perform and the necessities required for immunohistochemistry rather in cytology specimens. The nice thing about this molecular pathology explosion has been the ability to identify surrogates, immunohistochemistry surrogates for those molecular events and apply them to tissue specifically to try to identify specific entities based on immunohistochemistry. They can, and that's one of the exciting things that I was able to do over the last several years, being the director of immunohistochemistry here at MGH. You know, we have a colleague here at the Brigham and Women's Hospital just down the street known by Jason Hornick, who is, of course, the absolute kingpin of immunohistochemistry and soft tissue pathology. And it's always a bit of a game of catch up with him because he obviously develops a huge number of novel and important markers that my colleagues in this hospital all want to have. He's a wonderful person and he's very, very giving, and oftentimes helps us develop the stains in-house, but it's really allowed us to grow a huge number of markers, somewhat arbitrarily categorized here to identify specifically a soft tissue tumor on both core biopsies or on cytopathology. I think we're aware of some of them, those that result in abnormal cellular localization, such as beta-catenin, for instance, although I admittedly think it's a very challenging immunohistochemical marker to actually evaluate on tissue or small biopsies. But we have ones that are essentially surrogates of overexpression of other molecular events, ones that I think we're all very familiar with, such as TLE1 in synovial sarcoma, MUC4 and low-grade fibromyxoid sarcoma, or more recently CADM3 overexpression in superficial CD34 positive fibroblastic tumors. The alternate is also true. We have surrogates for loss of expression events such as MPNSTs, malignant peripheral nerve sheath tumors, that show mutations in EED or SUS12 that results in loss of trimethylation at H3 lysine 27. Amplification events are, of course, something that we're all quite aware of, things like MDM2 overamplification in D. diff liposarcomas or MYC amplification in radiation-associated angiosarcomas. Although not truly a amplification event, this emerging group of very interesting mutations, internal tandem duplications, such as those that occur in B core, originally described in clear cell sarcoma of kidney, where a short segment of the DNA is duplicated, resulting in loss of its ability to bind B core to bind to PCGF1, has also been identified in a subset of these sarcomas with B core genetic alterations. The reason why you end up having B core overexpression through immunohistochemistry in this setting, though, is still uncertain. Mutations leading to overexpression, we're all quite familiar with these, such as KIT or TP53. Mutations leading to loss of expression has become a very popular one recently in our laboratory. This on the right is SMAD4, but obviously those markers that target the SWE/SNF chromatin remodeling complex, such as INI1 in epithelioid sarcomas, has become extremely popular, as has SMARCA4 and ARID1A. But really the ones we've been most excited about in our laboratory, because it's probably the largest group that targets sarcoma specifically, have been markers that are overexpressed secondary to those gene fusions in particular, and you can see a list here. Rarely we see the opposite, where you actually have a gene fusion and you can identify the loss of expression, such as YAP1, if you use the C-terminus antibody, where you will lose the C-terminus expression in a subset of hemangioendotheliomas and some other malignancies, such as porocarcinomas. But the problem with all these markers that I've described so far is they essentially target the normal protein. And, with malignancies, especially high-grade malignancies, there's nothing stopping these tumors from overexpressing one marker or another, such as synovial sarcoma overexpressing B-core. It happens in a subset of cases. But what's really nice is the advent and development of some mutation-specific antibodies, those to IDH or H3F3A in giant cell tumor of bone, such as we have here on the right, or H3F3B in chondroblastomas. But finally, the holy grail. We finally have a mutation-specific marker that identifies the synovial sarcoma fusion specifically, can be utilized with synovial sarcoma, other synovial sarcoma markers such as TLE1 or SSX C-terminus to improve its specificity, but it has really been able to, in this case, identify those synovial sarcoma markers very specific, or synovial sarcomas very specifically, has been a godsend. But this is an international effort, and we certainly can't suggest that every entity needs some sort of ancillary testing. We need to accept the fact that we have various inputs from institutions all over the world. Not all institutions have the ancillary testing required for soft tissue tumors. In fact, not all institutions have the resources or even care for specialized treatment of these soft tissue tumors. So when we created this classification system, we really had to also offer some guidelines for what is the interpretation, what's the diagnosis for cytology cases where you only have the cytology alone. So let me talk a little bit about this international system for reporting cytopathology, the combined effort between the IAC and IARC through the WHO. A standing committee of members was created. This is Dr. Andrew Field from Australia. This is Dr. Fernando Schmidt from Portugal. Obviously, I mentioned Dr. Martha Pittman here from MGH. This is Dr. Ravi Mehrotra from India and Ian Cree from the WHO. And they sought to start to identify and create reporting systems in cytopathology for the WHO. They started with pulmonary, they are doing pancreatobiliary, lymph nodes, and decided to include soft tissue as well. And I know what you're thinking. Why are we not hearing about these other ones where they obviously have much greater applications to general practice? Obviously, lung, lymph node, and pancreaticobiliary cytopathology is much more popular, much more useful than soft tissue. And I completely agree with you. The problem is I was part of the soft tissue component, and this is what I'm here to promote. However, if you do want to hear more about the other reporting systems, if you had the chance to go to the ASC this year, they did present them at that time. Currently, I believe the pancreas and lymph node might be in the beta publications, which means that it is available for others to review, to critique and make comments about whether you think it is useful. But from our perspective, a group was created to report on soft tissue cytopathology. And so this was the cytopathology editorial board. Here on the top left is Dr. Jerzy Klianienko from France and Dr. Henrik Domansky from Lund, Sweden. Between these two, they have been publishing on soft tissue cytopathology for many, many decades and have quite a bit of experience and have really been great mentors to a lot of us over the years. They've been joined by Xiahua Chen, who's now in California, Dr. Beata Bode, who's in Switzerland, Dr. Leslie Dodd, who is currently in North Carolina, I believe, Dr. Bharat Rekhi, who is at the Tata Memorial Hospital in Mumbai, India, obviously has a huge fund just by volume alone of soft tissue tumors. And many of you are sure are aware of Dr. Vicky Jo, a very prolific friend of mine over at the Brigham and Women's Hospital. And this handsome young man here is me, just honored to be with this group, to be honest with you. So over the course of a couple of years, we decided to come together to propose the structure of this reporting system. We had the choice of going to Milan, we had the choice of going to Paris, we had the choice of potentially even going to Lyon, even Bethesda. But what we chose to do was do it over Zoom. Beautiful, beautiful Zoom. which was nice, I guess, because I got to stay home. But we proposed this structure of this book. Here you can see we started with some introductory chapters, including one on immunocytochemistry, which I suggest you read. It is the chapter that I wrote with my associate, Dr. Vicky Joe. And then we delved into what are the interpretive categories we thought that cytopathologists would require to render an interpretation. Some of these are going to be unique, and some of them are going to be pretty common. So I think we're all aware of non-diagnostic, benign, and atypical. The unique one here that we borrowed essentially from the salivary gland is this soft tissue neoplasm of uncertain malignant potential, which did have a significant amount of controversy when it was first proposed. Not all of us enjoyed or liked this category. The short term here is ST-NUMP or ST-NUMP, or the way I pronounce it, Saint Nump, which is, I guess, the patron saint of incomplete or indeterminate categories. And then finally, suspicious for malignancy and malignant. Each chapter is meant to link back to the WHO Blue Book surgical pathology chapters for the respective definition, clinical features, and histopathology. What's key for our volumes in particular are going to be these key diagnostic cytopathologic features and a discussion in the cytologic differential diagnosis for each of those entities. And finally, a subset of how ancillary testing would be required to render a specific interpretation in those categories. So as an example here, the chapter on synovial sarcoma, key diagnostic cytopathologic features in list form to make it easier for others to interpret. And if they need any further information from a histopathology perspective, these will be linked to the Blue Book online. Recognizing that not all tumors are necessarily neoplastic, in a lot of areas where they'll be more interested in recognizing non-neoplastic soft tissue tumors, we do have a section recognizing that. Here on the right is an example of fat necrosis, something that we see relatively commonly in our fine needle aspiration clinic. In our benign tumors, we sought to, instead of separating them by histogenesis as they did in the WHO, we recognize that a lot of these tumors we recognize based on their cytomorphology. And so we broke these down from a cytomorphologic perspective. Here on the first category being the adipocytic neoplasms. Here on the right, an example of a lipoblastoma. We recognize these hypervacuolated cells with these very, very small vacuoles, relatively bland nuclei. Tumors with myxoid stroma. Here's an example of intramuscular myxoma showing a hypocellular smear, abundant myxoid matrix, the lack of vasculature, and some characteristic skeletal muscle fibers within this aspirate itself. Spindle cell tumors, as I mentioned, characteristic feature of schwannoma, which can essentially be recognized based on cytomorphology alone, where you get these very cohesive groups of spindle cells with a significant amount of anisonucleosis, but lacks mitotic activity or necrosis, oftentimes with pointed ends and intranuclear inclusions. The periphery, you tend to see some fibrillary to fibrous matrix. Chondroosseous tumors, I have to admit, I don't think I've ever actually seen a case. This is an example of myositis ossificans where a diagnosis would really require clinical and radiologic correlation, plus or minus the addition of USP6 fusion identification as well to make the diagnosis, as identification of bone or bone or osteoid on cytology is exceptionally difficult. Finally, a class of epithelioid tumors in the benign category. Here, an example of tenosynovial giant cell tumors we see relatively commonly in our fine needle aspiration clinic, where you see this monomorphic population of cells with hemosiderin-laden macrophages, multinucleated giant cells scattered throughout, plus or minus chronic inflammatory cells and foamy macrophages. Now, this category of ST-NUMP, where as I mentioned, there was some controversy, occurred because we're classifying a couple of different things in this category. One are tumors where you recognize that there is a neoplasm there. It's an aspirate, it's clearly neoplastic for one reason or another, but because of a lack of ancillary testing or otherwise, you're uncertain of its differentiation. So that would be the first category you would place into an ST-NUMP category. The second that has also been included in this category, though, are entities where you are sure of the diagnosis, such as solitary fibrous tumor here on the right, showing a monomorphic single cell population of plump spindle cells with cytoplasmic processes, oftentimes with a lot of hemorrhage or blood in the background. You can confirm that diagnosis with the STAT6, CD34, for instance, on a cell block preparation, but we cannot determine its risk stratification because that would require identification of mitotic activity, for instance, on an excisional specimen. So this category and the category of uncertain differentiation were unfortunately grouped together. And in a discussion of this chapter, we really tried to root out where exactly this classification would help most in cytopathology soft tissue tumors. Finally, the malignant category, we again tried to subcategorize into differentiation. You can see here that dedifferentiated liposarcoma, although not being truly adipocytic in terms of its morphology, was included to try to tie it into its relationship with well-differentiated liposarcoma, except for, of course, in the rare situations where you have dedifferentiated liposarcoma transdifferentiating into a pleomorphic liposarcoma. Here on the right, in fact, is an example of a pleomorphic liposarcoma showing highly malignant cells with vacuolization consistent with pleomorphic lipoblasts. We also included a number of myxoid malignant neoplasms for unclear reasons. We did include chordoma. Here's an example of chordoma, which shows plump epithelioid cells in a loosely myxoid matrix here. We see it relatively commonly in our institution here because they have a subspecialty clinic for radiation therapy and chemotherapy for our chordoma patients. High-grade spindle cell sarcomas are relatively common. Here's an example of a leiomyosarcoma showing fascicles of hyperchromatic spindle cells, almost palisading in this example. High-grade epithelioid malignancies, such as here on the right, an example of an epithelioid sarcoma really showing features that resemble melanoma. I don't know if you guys are aware, but Dr. Selina, one of my colleagues, and I think he's now in Victoria, had published an example of epithelioid sarcoma rising in a patient who had a previous history of a melanoma, which I think is a very bold diagnosis to make, to be honest with you. Really does morphologically resemble melanoma, but you would identify with, expression pattern of keratin, CD34, perhaps ERG, and of course, loss of expression of INI1. Chondroosseous tumors, again, similar to the benign counterpart, are oftentimes very difficult to make a specific diagnosis on cytopathology alone. I've never seen an example where we clinically, or rather pathologically, made a diagnosis based solely on cytomorphology. There's not any great ancillary testing that'll help in that regard. This is one example, though, where we did see a patient in the FNA clinic with a small lesion in her forearm. It was aspirated and shown to me, where obviously very rare but scattered highly malignant cells, a diagnosis of a high-grade sarcoma was made. But our radiology colleagues, who are excellent in MSK radiology here, disagreed. They actually felt that the radiologic features were more consistent with nodular fasciitis. So of course, this morphology does not fit with nodular fasciitis. So I sweat for a couple of weeks while I pray that they resect this thing. They eventually resected, and sure enough, this example did turn out to be a small example of an extraskeletal osteosarcoma. Sorry about that. The pleomorphic category is relatively common as well. We see them not infrequently in our fine needle aspiration clinic. This one in the right, a pleomorphic or an undifferentiated pleomorphic sarcoma, rather, seen in our clinic, referred because they thought the patient had fibromatosis, but clearly the cytomorphology of large pleomorphic cells with a lot of necrotic debris in the background, characteristic of an undifferentiated high-grade sarcoma. Lastly, probably one of the most common things we do see biopsies of are the round cell sarcomas. Here's a list here. This is a recent example that I had seen of a young patient with a paraspinal mass. This turned out to be a neuroblastoma. We identified that with positivity for synaptophysin and FOX2B on cell block preparation. So some example reportings based on our system that we proposed. An example of a benign tumor here, such as nodular fasciitis, which I think are oftentimes readily identifiable, bland, plump myofibroblastic spindle cells and a loosely myxoid to fibrous stroma, usually rapidly growing small lesions in the forearms of young patients. We can make a diagnosis of nodular fasciitis, plus or minus the utility of USP6 if required. Here's an example where we put it into the soft tissue neoplasm of uncertain malignant potential category. This would be an example of a gastrointestinal stromal tumor where molecular, or rather immunohistochemical markers identified positive for KIT and DOG1, but we would not be able to risk stratify based solely on our cytomorphology or cell block preparation. Similarly, in that category of soft tissue neoplasm of uncertain malignant potential would be a case like this, where I really struggle to try to differentiate this tumor, a large retroperitoneal mass in a female patient where you could see a very monomorphic population of cells aligned along these vascular structures. No matter what stain I threw at it, and I was certain this was some form of dedifferentiated liposarcoma, but all our immunohistochemical markers came back negative. Frustrated with that, I would throw in a MDM2 FISH, it came back negative. So certain, in fact, that this was some sort of D-diff liposarcoma. I ended up sending it for SNP array, but as I was waiting for that, I obviously had to sign this out as a tumor of uncertain malignant potential, as I could not categorize it specifically. It did not turn out to be one of these rare CDK4 amplified D-diff liposarcomas. In fact, it came back with multiple genetic abnormalities, complex karyotype consistent with just a undifferentiated spindle cell sarcoma. Finally, an example of the malignant category here, a high-grade superficial malignant neoplasm showing abundant vasculature clinging on to some high-grade tumor cells that at high power are clearly very pleomorphic, embedded within this metachromatic matrix, a myxoid matrix consistent with a high-grade myxofibrosarcoma. Expected all markers would come back negative. Obviously, as I mentioned, these were not without controversies, these meetings over Zoom, and there are a couple of areas where we couldn't completely agree on how best to categorize these tumors. One in particular that was surprising was how to classify adequacy in soft tissue tumors. If you were to ask me what is adequate, it would be where I could render an interpretation of at least a typical, give it hopefully a neoplastic, hopefully a specific interpretation, but some interpretation. For instance, if I were to see this patient in the FNA clinic and I would have do ultrasound or have some radiologic features that were not suggestive of fat, but I aspirated and get nothing but fat, I would call that non-diagnostic. Whereas if I saw the same patient and it felt like lipoma, and by imaging, if we had it available, like ultrasound or cross-sectional imaging looks like a lipoma and I aspirated, I call it a lipoma. Those are the same morphologies, but two different interpretations, either inadequate, non-diagnostic, or benign lipoma. However, there are colleagues, especially those outside of the United States, who felt that the diagnosis was based on whatever was on the slide. So if you see benign adipocytes on the slide, you call it benign, not non-diagnostic, and send this back to the clinical team for correlation with what they have seen, for instance. And we went back and forth and eventually decided that we were not going to agree on what the criteria of adequacy was in this interpretation. And therefore, we're just going to have a longer discussion in our reports about what to best do with these cases. The other interesting thing was some controversy over what to do with the atypical category. In fact, some members argued for the complete abolishment of this category altogether because it was essentially ignored by their clinical colleagues. But, you know, although it is extremely difficult to define what atypia is in soft tissue cytopathology, especially since we're well aware of some very bland-looking tumors that are malignant sarcomas, as well as some very pleomorphic looking tumors that are completely benign in soft tissue, how best to classify what exactly is an atypia in soft tissue cytopathology. We will obviously still require this category. It's something that's been ingrained in cytopathology for some time. And so we do have a discussion around how to best approach atypia in cytopathology, soft tissue tumors. I mentioned already the controversy around this ST-NUMP category, whether you like the name or not. I think you can tell what my opinion about it is. But I think my biggest issue with this is that we're really mixing cases together. We're mixing cases that have no definitive diagnosis but are clearly neoplastic, as well as tumors that are, we know the diagnosis, we just cannot classify their risk based on their cytomorphology or ancillary testing. And that really will mess with our risk of malignancy, which we try to establish for these individual categories. In fact, the interpretive category risk stratification is an important part of a lot of these cytopathology reporting systems. And you can see here at least one element or one attempt at this recently large study from our friends in Sweden trying to categorize each of these in terms of the risk of malignancy, showing somewhat a rising risk of malignancy as we head towards malignant. But you can see within the atypical category, we do have a pretty significantly high risk of malignant. Some institutions here in the United States have attempted something similar. I think one of the big problems, though, with trying to identify risk of malignancy in the United States is follow-up. Unfortunately, because for instance, in Vancouver, where you'll have a very unified population within the catchment area that come get a biopsy, get treatment, all within British Columbia, you'll have that information from start to finish. Whereas in the United States, they have a tendency to shop around. They'll receive the biopsy and diagnosis here. They'll be resected in New York or at the Brigham Women's Hospital. So we don't necessarily have follow-up cleanly for all our biopsies of soft tissue tumors on cytology. But this at least suggests that there is a way to risk stratify these tumors, although I would like to see our atypical diagnosis a little bit less malignant. There was some discussion about whether or not certain entities should be included or not, whether or not we had sufficient fund of knowledge for some of these entities. I'm happy to report at least a few of these have been eliminated. I don't think we do have experience enough to suggest that there are cytologic criteria for these. One in particular was adult fibrosarcoma, which some of us fought quite heavily because felt that this was not really an entity anymore, whereas others, especially internationally, suggested this was and should still be in our reporting system. Whether or not Kaposi sarcoma was considered a malignant tumor was also somewhat controversial. We ended up keeping it in that category. So some future problems. I think one of the things that any reporting system in cytopathology really requires is both an accurate risk stratification, which we're hopefully trying to work on, but more importantly, some management algorithms. What are the management given our interpretive categories? The problem being, especially from soft tissue perspective and sarcoma treatment, is that can vary quite significantly by both the diagnosis, the site, the institution, what resources those institutions have available. And because of all those variables, it becomes very difficult to try to have a cohesive management algorithm, such as what they can do for the thyroid, for instance. We were hoping to have our publication done, including management algorithms, by the end of this year. Unfortunately, that's not going to happen. So I expect we will be working out some of these management algorithms, at least generally speaking, by middle of next year. And of course, as I've talked about before, there's going to be a subset of entities that just cannot be diagnosed by cytology, regardless of what we do, regardless of the morphology or the ancillary testing. That group continues to narrow all the time as we start to identify more and more specific molecular markers, as well as immunohistochemical markers that are targeting those specific fusion products. So hopefully eventually we'll get there, but obviously we do have some limitations to our abilities. With that, let's get back to our case presentation here. So this was that monomorphic spindle cell malignancy, or rather spindle cell tumor we had seen in the temple of a 21-year-old male. The cytopathologist, recognizing that this would require ancillary testing, produced a cell block, and this is indeed a cell block from our FNA clinic, not a core biopsy, showing both spindle cell morphology as well as maybe some plump epithelioid morphology. It was sent to me for interpretation. A number of immunohistochemical markers were performed, all of which came back negative, except for TLE1, which showed diffuse strong nuclear positivity. It was subsequently sent for molecular testing, which identified the fusion product of synovial sarcoma, and a definitive diagnosis of synovial sarcoma was made. So with that example and what I've discussed today, I think I've been able to outline where I think the World Health Organization requires another reporting system to help to categorize the soft tissue tumors based on their cytomorphology. And hopefully in the future, we'll be able to develop some more specific management algorithms to help supplement this reporting system. I really do appreciate your time. Thank you for allowing me to present this to you. And I'm more than willing to take any questions if there are any.
Thank you, Ivan, for such a wonderful talk. You have went through a